Welcome, everybody. If you're here for the Varithena Boston Scientific sponsored symposium, you're in the right place. I am Keith Sterling. I'm an interventional radiologist, and I am the Senior Medical Director for our Peripheral Interventions Division at Boston Scientific. I am really happy to introduce my co-panelists who are well known in this venous space. Dr. Lowell Kabnick of Vein and Lymphatic University, which it says somewhere in New Jersey, but I think it's worldwide. And Dr. Vinay Satwah, who is an interventional cardiologist with the Center for Vascular Medicine in Greenbelt, Maryland. So thank you both for being here. And I think we got a really great symposium for you people. Okay. So please take out your phones. Normally when I'm giving a talk, I would prefer you're off your phone, but you're going to be participating here. And we have some surveys for you and just some questions to kind of get an idea of where people are at with Varithena and their experience. So we're going to close the poll in a couple minutes when I kind of get a sense that everybody's voted. And we're going to show you the results of this. That's really important for our team. And you guys are going to put up the, Roseanne, you'll put up the results? Or do I go next slide? All right. Well, it looks like we have more than 16 people in the audience, but okay, so we have, people are using Varithena, perfect. Oh, well.
Apple is accusing you of impersonating somebody, so I actually can't know.
Can you go to the other QR code? Well, hold on. Is that next survey question come up? All right, so if you're not using Varithena, and I think you may have the ability to vote for more than one here, let us know what the barriers are, if there are any. Great, so we have things that we're going to talk about that address certainly number one, for sure. Okay, next question. How familiar are you with the Varithena network meta-analysis? Okay. All right. Well, I think the previous one is a little more instructive. All right, so we have work to do here today. So with that, and there'll be a couple more polling questions later on, but with that, oh. Who's controlling? Me or you? Okay. All right. I'm going to give this to you. So I'd like to have Dr. Kabnick's going to give us a talk, and he's going to Phil Donahue us. So he's going to stand up and walk around.
So we're all here to have some fun. Hopefully you're enjoying your meal. And this is where I am. I'm totally conflicted. Totally. By the way, I'm not doing that. So if you would go back. So I'm totally conflicted, and what's more, I'm more conflicted about my wife jumping horses. So that being said, let's move on. So why I chose Varithena over physician compounded foam. Number one, it's FDA approved. Number two, it's safe. Number three, it's effective. And four, I know pretty much what I'm getting. It's pretty standard. So Varithena has been optimized for safety. And one of the things that I learned, I drink a lot of bubble water or sparkling water, and everyone tastes a little bit different, and it really has to do with bubble size. And I think the bubble size is important as we talk about this in comparison to physician compounded foam. And then the idea of the nitrogen, which is very little in this as compared to physician compounded foam. And so one of the things, I was involved in phase 2 and phase 3 trials of Varisolve, better known as Varithena. And one of the things that the FDA made us stop right away was to check about, patients that had PFOs and if there was any neurological compromise, because we knew that physician compounded foam, there were starting to be reports of issues. So if you look at this, there were 82 patients enrolled in the study. Of the 82, 61 had shunt positive, 21 were shunt negative. And you would think, from the cadaver studies that it was only 25% that had a PFO. But in this study, it's pretty high. It was somewhere around 59% that had PFOs. So, and that's with patients that have varicose veins. So that was a subset. 60 with middle cerebral artery bubble emboli detected on transcranial Doppler. Post-treatment surveillance with MRI, neurologic exam, and visual field tests. Can you imagine subjecting your patient to 3 MRIs? Anyway, that being said, there was no evidence of cerebral or cardiac microinfarction despite migration of bubbles to general circulation. And that may not be true of physician compounded foam. So with that being said, once we did that, the FDA came out suggesting that there's a difference between physician compounded foam and Varithena, and they thought that perhaps we should not be mixing room air with either polydocanol or sotradecol. And the majority of us received a letter. This was written to an industry that was either manufacturing or distributing sotradecol as well as polydocanol. So I know what I'm using in terms of Varithena. This is pretty much what people know about it. But I think the real thing is that I didn't quite understand is the ratio of gas to liquid. And the thing is that the more gas you use, the more drier the foam is, and perhaps the stronger it is. And it's nice to see Dave Wright in the audience, who was instrumental in torturing us with all of these trials. Thank you, Dave. It was one of the best trials that I've been involved in and one of the most accurate. And so then you can see the high CO2 foams that we use are less stable, but you can see the ratio here, 65%, 35% O2 and CO2 with really not a lot of nitrogen. So it makes you comfortable in terms of what you're using. If we look at the papers that are out there, and these are just some of the papers, one of the interesting things was a Deek paper, and Deek is a colleague of mine in New Jersey, 250 patients treated with Varithena with a 94.4% closure rate and less than 1% DVT. But each one of these had their appearance. So looking at this, it was something that I thought was really important. A group of us got together to start looking at all of the papers that were published. And let me tell you, it was a great undertaking. And so we know that a meta-analysis and a systematic review has got the highest level of evidence. So the study objective, and I'm going to read this to you, was to compare the effectiveness and safety of polydocanol 1% endovenous microfoam ablation, better known as PEM, versus endovenous thermal ablation with radiofrequency or laser in the treatment of adult patients with venous insufficiency caused by lower extremity truncal vein incompetence. The design, a systematic review of the published comparative evidence, randomized or non-randomized, incorporated into a network meta-analysis. So when we looked at the systematic review results, there were 2,000 eligible studies. Of the 2,000 eligible studies, after we got through looking at it, there were 13 studies that met our eligibility criteria for the network meta-analysis. 6 randomized trials and 7 non-randomized comparative results. And I can tell you, ladies and gentlemen, it was an arduous task that anybody that's ever gone through it. So just to wrap up in conclusion, and by the way, tomorrow I'll present the whole lecture, actually abstract on this. So PEM was not statistically different from endothermal ablation for vein closure and DVT risk for chronic venous insufficiency treatment. PEM was statistically significantly differentiated from physician-compounded foam with higher odds for vein closure. For vein closure, polydocanol 1% endovenous microfoam was not statistically significant statistically from endovenous thermal ablation for venous closure follow-up intervals of 12 months or greater, up to 6 years. And ladies and gentlemen, this is going to be a living meta-analysis. So every quarter, we're going to review the literature and update our statistics. So far, we've looked at it twice, and there's been no difference. So be aware that this will be going on, and you'll be able to update through that website. So that being said, my co-authors, and I want to thank all of them, but for the physicians was Juan Carlos Jimenez, Sheila Kogan, and Kathleen Osvath. And the rest of the people up there should also be mentioned because they were instrumental in helping us a lot with statistics. And as you know, statistics can be challenging for anybody. So let's look at a case presentation. So I'm going to present a 66-year-old male complaining of varicose veins for many years with symptoms of heaviness, aching, throbbing, right leg, no history of DVT, reports right leg skin rash, he's worn compression hose, which does help him, and he has a job that interferes with his quality of life because he stands. If you look at the rest of the past medical history, past surgical history, medications really non-contributory. Right leg extremity varicose veins, medial aspect of the leg, zone of influence, the great saphenous vein, brownish discoloration with induration of the skin, supramolecular, no ulcers or pulses, and pulses are equal and bilateral. So the impression was right leg, symptomatic, varicose veins, C4B. The plan was duplex ultrasound and then question mark venous intervention. So you can see the medial aspect of the leg, the varicosities. And this was the venous map. Reflux, as you see, the great saphenous vein, again with the tributaries drawn. And of note, there is no iliofemoral obstruction and no DVT. So I began to agree in my head that this patient would better be served with an intervention. And I chose Varithena for this particular case. And these are the supplies that come with the kit. And as we look at it from bottom, this is a micro puncture set. This is the transfer pack that you can use here, and there's actually one in place. And then the syringe that comes with it that's specially not treated. And then the tubing that comes with it. And more importantly, the eccentric compression that I believe Dave Wright had some patent on it, right? No, but was definitely involved in it. So if you look at this, this is what we looked at. And as you can see, I have entrance at the knee level as well as just supramolecular. And there's saline, heparinized saline in each syringe. I don't use heparinized saline anymore, but you can see they're attached. The tubing takes approximately 1 milliliter, and I think you actually say 1.1 milliliters, and that's it. The introducer, again, is 21 gauge with an 018 wire and a 5 French sheath. So that being said, this is how we're lined up and ready to go. And the question is, how do you do this? And so if you look at this, I'm actually following the Varithena up toward the junction because I believe in treating the thigh first. And then when we get up to the junction, I'm going to compress it so that there's no progression there. And I hold it for a couple of minutes. And then down on the bottom screen, after I've done the procedure, you can see there the bubble formation of Varithena. And then the most complex part of it, which some of us have changed, is a very significant wrap that stays on originally for a couple of weeks, and I think we've all modified that as well. But I think what's important is certainly the eccentric compression, and how long you keep that on is relative. David, I have a question. Did they ever do any control with or without on the 2-week compression? Speak into my microphone.
We looked at this, and the issue, if you left compression off at a week, that which was compression stockings by then, there was a higher incidence of superficial thrombophlebitis. If you kept them on for 2 weeks, it was absent.
So I submit that I've not seen it. Have you seen it? Okay. Anyway, moving along, I'd like to thank you for the opportunity of presenting some of our meta-analysis, and tomorrow I'll present it in detail. And thank you for allowing me to present a case.
Yeah. So I just want to keep you guys engaged, active, and so although we'll have time for questions later, does anybody have any questions now? Anything? This was kind of like your bread and butter case. We have mics rotating. Lowell, I'm going to ask you a question. How do you decide kind of whether you're going to do non-thermal, non-tumescent with Varithena versus thermal? I think that's probably a big question. That was a bread and butter case, basically. And just give your opinion on that.
So it's fairly straightforward at this point. We have secondary indications for Varithena and not primary indication. So in this particular case, I cheated because I needed to do the whole thing. But the reality is that I come back and do infrapopliteal treatment with Varithena standardly. And then for the central portion of the great saphenous vein, I typically will use thermal.
Okay, how about you, Vinay?
So from my standpoint, I agree with Dr. Kabnick in that, thermal obviously has a place, but for non-thermal, non-tumescent modalities like Varithena, it helps particularly in my practice in those patients that have distal GSV reflux, that we're worried about thermal injury and neuropathy. I like it a lot in my recanalized patients. If you do it long enough, you get patients that come back, right, that have veins that have opened back up over time. And this is very nice where this liquid foam allows you to get into those areas where the pockets of reflux exist in these symptomatic patients. And then finally, I have a very nice case on patients that have active ulcers, which I'm looking forward to share with you.
Awesome. And then one other question before we go on.
Right.
Volume. How do you figure out what the volume is besides?
Yeah, no, that's a great question. You ask 5 different
it.
people, you get 5 probably different answers. I really think it depends on the patient. It depends on what their SEEP class is and the complexity of the vascular disease, the vein disease, how long is the vein that you're treating. So from my standpoint, I'll share with you, I do treat GSVs above and below the knee. Varithena is indicated, FDA approved for GSVs above and below the knee. And so typically if I'm doing a full length GSV, typically it's about 10 to 12 cc's for the entire segment. 5 to 6 cc's above in the thigh and another 5 to 6 cc's in the calf segment. But if it's more like a focal area that I'm treating that is focal to an ulceration, I might cut back on it and maybe between 3 to 4 cc's. How about you, Doctor?
So that's kind of an interesting soliloquy that you mentioned. So I'm going to ask this question. So when you treat the great saphenous vein, you treat the great saphenous vein in entirety. So you don't get paid for the majority of times for the central portion. And if you're doing this as a primary, how do you get paid? Because in most insurance companies at this point will only pay for secondaries, which you mentioned. For me, I watch and see what's happening with the foam. And for me, I think you're spot on. In our trial, it was certainly more than 5 cc's. But I think at this point in time, I agree with you in terms of above and below in that denomination. But everybody's a little different, and I've seen a whole lot of variability out there in terms of treatment.
Great. Yeah, we have mics. Just raise your hand and we'll bring a mic over to you. Right here, Karen.
So I've always thought that Varithena, at least in Ohio, we have not had an issue of being paid for the truncal vein treatment, whether it's above or below the knee.
That's true.
We had the problem of getting the other way around, getting paid for it, but now that's getting better too. But this is probably the fourth year we are having this conference here. We still keep saying above and below the knee.
Okay.
The whole idea is one procedure, one case, one and done. Insurance companies are pushing you to do that. It's cheaper for them rather than combining. The only thing that's keeping us from doing it is we get 2 reimbursements, one for thermal or whatever it is and all that. And a lot of these people, C4 disease and beyond, have complex disease, they have multi-level disease and all of that stuff. So you anyway have to use something other than a or a thermal modality. So I think that's where the industry should push for this to be treated, and we should push as practitioners that treat this one and done. That's
So well, let me ask the audience a question. How many people use, now I agree with you, Varithena will go above the knee as well. So if I'm treating below the knee, I'm also treating above the knee. But I can tell you that my go-to choice is still thermal above the knee. I want to know in the audience, how many people still use thermal above the knee? How many people use only foam above the knee? Okay. And how many people believe that you can treat the above knee, their insurance companies will pay for primary? Okay. I'm moving to your state.
That was true, and I can tell you in our geography.
Yes.
Okay. So why, if it is, why are people still using thermal? Be one and done. We can't hear you very well. So would you use that?
I think the reason why your meta-analysis really has taught me that it is non-inferior. I've always, in my clinical practice, I have seen it to be inferior to thermal ablation for treating the axial truncal vein reflux. So I think, but this is showing us that it's better. We have gotten better at it, and we're picking the right cases. So again, one and done.
Yeah.
Nobody disagrees with the one and done philosophy. But I'm going to ask one of my colleagues, if I may. You can talk into my microphone. I'm coming over. You know exactly. Wendy Whiffler is vice president, and she knows more about stuff than I do. Is it true that we can do primary closures now with insurance companies? Do insurance companies allow primary?
Yes, the majority of insurers in
I'm not
the
talking
United States
secondary, I'm talking primary.
allow primary. It is a minority. I'm going to say less than 10 policies limit to secondary treatment.
Yes, that's
So
correct.
90%
That's
of
correct.
of
And
Does United
about 90. Dirk?
Does United allow primary, or is it just secondary?
It's not stated. Yeah.
I know it was secondary.
No.
so
Anyway, it's nice to see that we're progressing.
Right.
So thank you, Wendy.
if I can, I think that that's going to be the power of the meta-analysis and the fact that it's a living document, because I think that it's going to help, and it's already helping, change the minds of payers to allow for not only primary, but to show this non-inferiority. So this idea that we've been doing thermal for 20 years and it works, this is going to be a really amazing non-thermal technique for your patient.
It'd be interesting to see the shift from thermal to non-thermal using Varithena. And
It's kind of like the shift
looking.
from open aneurysm repair to endo. So,
we'll try stripping
Right.
in this field.
Yeah.
All right.
Absolutely. Well, thank you. No, this is great. I mean, these are the wonderful opportunities we have to share this type of information with one another, and we all learn something. And again, kudos to our pioneers many of them are here in this room today that have put years and years of hard work into getting us to this point. And it's up to us now, and I appreciate your passion, doctor. Every year you come and you give great commentary on this, that we have to continue to push that envelope and help give these cases that we do on these patients, submit these cases and show ultimately these insurance companies that Varithena does work. And yes, it does depend on where you're at, your local care determinants, obviously where you're practicing. Obviously that's beyond the scope of this, but Boston Scientific has wonderful resources that they've put together. Many of them are in this room here today. These individuals are experts at letting you know what your local area care determinant is, what the reimbursement looks like, and what insurance companies are on par and not. So I would certainly encourage you to tap into that resource if you can. My job today is just going to be to go over a couple more cases with you all, just to show you how Varithena, to my practice, our practice in Maryland, has brought such versatility. The first case, this is a patient, she came to our practice, she's a 52-year-old Hispanic female, comes in very, very emotional. She's upset because she's worried that she's going to lose her job. She's a local housekeeper at one of the Marriotts. And she says that, doctor, I need your help. I really want to make sure that I don't lose my job. I'm a single parent. My daughter's going to college next year, and I want to make sure that I can send her to college. And I said, all right, well, what's going on here? What's the emotion? What's happening? She said, well, I've been having pain in my right leg for many years, but doctor, I work. And so I'm supposed to have pain. I'm on my legs for long periods of time, right? Doing different things, picking things, lifting things, that type of thing. But what's happening now over the last 6 months or so is that my bulging veins on my knees are starting to bother me so much that there's been an episode or two where I was actually bending and one of the veins actually broke and I was having bleeding on the job. And so a lot of my coworkers, it freaked them out. I mean, think about it, she's got blood everywhere. They called 911, she went to the hospital, how that goes. So she's very, very, very nervous that one day they're gonna tell her that, hey, listen, you're not gonna be able to do this job anymore because of all these bleeding varices. And also the fact that she's having the heaviness and the achiness and the inability to carry her daily functions. She obviously is in a lot of stress. Ladies and gentlemen, this is what her right leg looks like, left and right leg. You can see the amount of varicosities, particularly concentrated on that anterior knee segment. And you can imagine that when she's bending, and that's a very mobile area, that skin is being pulled, those veins are being stretched, and potentially if she's on her knee, they could potentially burst and bleed, right? So obviously this is a real case scenario. This happens. We've seen patients like this that come through in our practices, right? And then the first thing obviously is to make sure that they understand that, yes, we can help them, right? They don't have to go through life suffering from this. But the next question is they need to know what the options are out there. First and foremost, bread and butter, vascular ultrasound is very important. We know that that is the basis on what we make our decision making on, right? It's important to invest in your vascular techs in your program. Doing a vein study is not just doing a DVT rule out. We know that, right? We have to invest in their education, make sure they understand how to look for reflux, how to do the maneuvers. We have multiple pioneers here today, even in the room, that develop these wonderful programs for vascular techs in the country. And so really important. So goes without saying that this patient had reflux in her right GSV, greater than 2 seconds, and the GSV ranged from 4.5 to 6 millimeters in diameter. We know that the studies incorporated veins from 25 up to 25.9 millimeters in diameter. So when you worry about, is a vein too large, just know, I'm not saying that every 25 millimeter vein should get Varithena, but just know that these veins were included in the studies. So anyway, in her situation, her largest her largest diameter was 6 millimeters. But what was also interesting was from that GSV, she had varicosities that were feeding, she had tributaries that were feeding into those varices. And it's important to understand that Varithena is FDA approved and indicated for GSV reflux with incompetent tributaries into varicosities like this patient has. And all greater than 3 seconds of reflux also in the varicosities. So we sat down and we talked a little bit about the options, right? And so what's going on in my mind is, yeah, thermal exists, but my goodness, these varicosities that she's got across her knee joint. I know that phlebectomy is very important. I perform phlebectomy in my office. I think it's an important tool to have. But we also understand that when you do phlebectomy, when you break the skin, you have to be cognizant of where you're breaking that skin. Are you breaking skin around an ulcer? Are you breaking skin around an area where the knee is going to continue to bend? So for me, I was very nervous. I didn't want to make too many stab incisions across that area because I was concerned also about potential neuropathy that can occur from poking around and pulling in there, right? And so we chatted a little bit about the options. And she said, doctor, listen, at this point, I'm at your mercy. Please help me. I really want to get better so I can go back to work and I can make sure that, I can, have a living for my family. So the first thing is really important. So again, I'm by no means a national expert on this. I learned, I made all the mistakes. So I'm here to make sure that I share those mistakes with y'all. First things first, you have to treat this as an ablative modality. This is chemical ablation. This is not just injecting foam and calling it a day, right? So there's a process behind this. We have to make sure that we get the patient set up in a certain way, make sure that we elevate the legs. It's important to elevate and drain the veins as much as possible prior to injecting the medicine, right? And so my approach, and I appreciate you being here, my approach is very similar to Dr. Kabnick's in that you want to split the difference. So she had reflux to her mid-thigh and then everything below into the calf. And so for me, one of my initial mistakes was, let me get access as low as possible in that GSV and start injecting foam and see how this goes. Well, what was happening initially in my practice was that I was not getting good proximal GSV closures. And I thought about it, and it made sense. Why am I not getting good closures? Because I'm expecting all that medicine to make its way up, track its way into that GSV, and potentially have the same potency as it did down on the calf. And I don't think that's fair. So what I started doing was I started splitting the difference, and I would get access in the distal knee, in the thigh segment first, give that potent 4 or 5 cc's of medicine, and then get secondary access in the calf, or the distal calf, where we can get the additional potent medication, and my closure rates went up significantly. That's exactly what we did here. The other thing is getting access prior to elevating the leg is probably a good idea because every now and then, when you elevate the leg, especially after 3-4 minutes, that GSV will shrink and it might make your life a little bit more difficult. So go ahead, get the access, put the sheath in. No matter how good you are at getting access, don't use a 21 gauge needle and inject the Varithena through there. No matter how good you are, when you elevate that leg, that 21 gauge will get disengaged. And then you're just going to start injecting subintimal, and you don't want to do that, right? So please, for the sake of having stable access, use a sheath. It's very good practice. Access, put the sheath in, elevate for at least 3 to 5 minutes, let that vein drain. In the meantime, check for perforators, right? Really important, no matter how good your vascular tech is, you want to just double check and make sure that there's nothing that potentially was missed. Make sure you mark the perforators so as the medicine's making its way up, you can compress those perforators. So that's exactly what we did. Injected 5 cc's in the thigh, 5 cc's in the calf. Now the next question was, what was I going to do about those varicosities? Am I going to go in there and I'm going to start lancing away, or is there a potential way that I can get some Varithena into those areas and really compress that down to get those varicosities to close? Because that can come at an expense of thrombophlebitis, right? If that blood is hanging out in there and you don't compress it well enough, you don't drain it well enough, well, where's that blood going to go, right? It's going to get thrombosed. And so that's going to come back with a patient that's unhappy and a lot of pain. So for me, it was a catch-22. I was trying to figure out, should I do extensive phlebectomy in that area, or should I try to get the medicine to track up into those tributaries and then compress the heck out of that thing? And she again was locked in. She said, doctor, I will compress my leg. I will do exactly what you want me to do. Because again, that compliance is super important and setting the expectation is very important. Well, how did she do? She came in at 3 months. Take a look at this. You can start to see the varices going down. And then also you can start to see her swelling coming down on that right leg, right? Usually swelling is the last symptom that starts to improve. Ladies and gentlemen, take a look at this. At 6 months, 6 months, you saw the varicosities come down very nicely. No longer is she having varicosities there. Her swelling has gone down significantly. She's obviously a very happy patient. I can tell you that not a week, not 2 weeks goes by that we don't get somebody coming from the local Marriott going, hey, I work with that patient and I saw what you did for her, and I can see not only did she get a promotion, but she's just so happy. She feels so energetic. Can you help me feel that way? And this is real life, ladies and gentlemen. These are patients that are walking around that have these issues, and we are here to help serve this undiagnosed or underdiagnosed disease modality. My second case presentation is what I had mentioned before.
Before you go on.
Yes, sir.
So one of the things I didn't cover, I'm glad you covered the elevation. That was really good. How long do you ask your patients to walk before you discharge them?
Very good. So what I will do after I compress, after I wrap their legs, I'll ask them to do some laps up and down the hallway. I usually have them do 8 to 10 laps. But for my more active patients where I know they're gonna be doing stuff, I just tell them walk 45 minutes to an hour afterwards, whether it's the supermarket, outside, wherever they choose to do. But that's the good point. Not go home and say this is a bed rest procedure, because it's not.
Let me ask you a question. So when you're doing your ankle or below knee access, do you ever use other adjuvant techniques to prevent the Varithena going into the perforators and subsequently into the deep systems, such as calf compression?
That's a great question, Dr. Sterling. Absolutely. So one of my first and initial, hesitations of using Varithena was, hey, this is liquid. This is going to go into potentially the deep system, and I'm going to get elevated DVT risk, right? But to Dr. Sterling's point, there are maneuvers and techniques that one can do. One of the very simple ones is dorsiflexing the foot. When you dorsiflex the foot, the calf muscle compresses. When the calf muscle compresses, it squeezes on the perforators and kind of closes those off and decreases the amount of potential leakage into the deep system. What about you, Dr. Kabnick? Anything else you add to that?
No, elevation and dorsiflexion, but I wanted to ask you about using Varithena along with phlebectomy, because I find that very effective and it limits my amount of phlebectomy.
Absolutely. Absolutely, you're right. Again, you'll be proud of me as an interventional cardiologist. I do perform phlebectomies. Yes, sir. Thank you. But I agree with you in that phlebectomies are important, and making sure that we know where to break the vein is really important as well because of the healing issues. So I think that one of the other ways that this has helped my practice is decreasing the amount of phlebectomy stabs. So now rather than doing a 20 plus
Do you
phlebectomy.
use the word stab?
Well, try to be like a surgeon. No,
Microphlebectomy.
Microphlebectomy, yes, sir. So microphlebectomies, breaks in the skin, right? So you have to understand that this is a healing process that comes along with that. So the amount of breaks in the skin have decreased for me. So I will break the vein, I'll decompress it, pull out whatever I can, and then I will inject Varithena in the remaining segments and compress the heck out of it to make sure that you get good vein closure there.
So do you insert your needle when the patient's still elevated at 45 degrees? Or do you use butterflies and tape them before you elevate? How do you do it?
So what I typically do is I will go ahead and put a 5 French. I prefer 5 French sheets just because of the tissue.
Not talking about the truncal vein, but the
Varicosities?
Varicosities.
So it's very hard to get a sheath into a varicosity, to your point, because of the tortuosity. So what I'll typically do is I'll use a 23 or 25 gauge butterfly and then try to eject as distal as possible and let that medicine make its way up and coat those veins. What about you, Doc?
Exactly. So I insert them before I elevate the leg. Otherwise, it gets very difficult.
Exactly. Dr. Sterling, anything to add there, sir?
Yeah, no, perfect. Actually, sometimes what I would use to minimize my catheter size is use the transitional or inner dilator for the micropuncture kit.
Yes,
But
very nice.
That's
nice
a very
technique.
interventional radiology thing to do. So, all right, you want to go on to your next case?
Yes, my final case. So this is a 46-year-old ICU nurse, a very bright young lady that comes to us. This is a woman who's in healthcare. She's an ICU nurse for 18 years. She comes to the practice, she's got ankle pain in the right side, hyperpigmentation, and some skin breakdown, she says. She says she's been dealing with this for a while, but she said, Doc, I'm a nurse. My job is to help people, and it's okay. Like, I have a little bit of, changes in my skin or whatever. I didn't really think much of it. I threw on some compression stockings and I called it a day, right? But what was going on, unfortunately, ladies and gentlemen, is that this skin coloration, she said, the discoloration is starting to worsen. And it worsened to the point now where she's starting to get her skin breaking down. And she came again very nervous and anxious because she said, I have a brother who had an amputation. And I'm very, very afraid that I'm going to lose my foot, doctor. Can you please make sure, please help me. I'm very young. I don't want this to happen to me as well. And obviously we sat down, we kind of went through what's going on. She was evaluated. She said, I was seen by my primary care doctor and I was placed on antibiotics because they were concerned about potentially an infectious process occurring. And they said, we're going to recommend you for wound care and see what the wound care doctors can do. Well, one night, again, she was very nervous. She was on her shift, and one of the vascular surgery medicine PAs were making her rounds. And she pulled her aside and she said, hey, can you do me a favor? I'm really concerned about this. can you take a look at my right ankle? Can you see what this is about? Can you help me? Can you give me some guidance here? And very, very astutely, she said, listen, I think the antibiotics, I mean, that's a moot point. I think at this point, you really need to have an evaluation, particularly of your venous system. And ladies and gentlemen, I mean, it doesn't take a rocket science. I think everybody in this room in 0.2 seconds looked at it and goes, that's venous insufficiency. But this is an ICU nurse who's walking around with this. It's our responsibility to continue to promote this in our communities and make sure people stay on top of this venous insufficiency disease process. Dr. Kabnick goes around the world, not only just around the country, but around the world to help underserved populations. And so again, it's an absolute honor to be here with you, sir. So we did a vein ultrasound on this patient. Obviously, you know, bread and butter stuff, not particularly surprising. She had reflux in her right GSV, right? Saphenofemoral junction to mid-calf with distal saphenous tributaries. Saphenous tributaries that were very interestingly, you can follow it with ultrasound going into the base of the actual ulceration. It's a very neat thing to see. I'm sure you've seen it in your vascular labs, but it's a very cool, interesting, it lights up at the end of the day. My vascular tech says it's lighting up like a Christmas tree, right? And so very, very interesting to see that. The other thing was that the GSV was tortuous. It left the saphenous compartment and came back down. That was one thing that she also mentioned. So what are our options here? And again, these are rhetorical questions. Are we gonna continue compression and say, hey, let's see what wound care does? Maybe. Are we gonna assess for infectious causes? Should we do a further ID workup? Should we treat the incompetent GSV? Or should we go ahead and check for suprainguinal venous insufficiency? Well, in this particular scenario, a patient that's coming to you, she's got C6 disease, she's tried the compression, she has reflux, common things being common, let's go ahead and treat that GSV. Now, we have to sit down and talk about the treatment options. And again, option number one, nobody's gonna stand here and say thermal doesn't work. We know thermal works. Thermal is very essential to our practices. It's very durable, right? And so, but we have to understand that there are limitations that exist with this, whether it's tortuous anatomy, distal, again, nerve injury that could potentially occur. And the question I had in this particular situation was, which modality is gonna give me the best way to close this ulcer, right? The highest chances of closing this ulcer. We know that there's microvascular disease that is at the base of that ulcer. What's gonna get into there? And for me, it made sense. Liquid foam. We have it, we should use it. We need to add it to our tool belt if we don't have it already. We're doing our patients a disservice if we don't offer this to them, right? I'm not gonna go through this step by step, but I think we've gone through the process of setting the patient up, injecting the medication, and then following these patients up. Compression is really important, like Dr. Kabnick said. Make sure these patients understand that that compression is gonna be critical in helping some of these veins close down. And so we went ahead and it was very neat to be able to see that medicine go into the base of the ulceration. She came back at 3 months, ladies and gentlemen, look at that. Already got it to close. Look at this at 6 months. You can see the hyperpigmentation go down. But this one's my favorite. Look at 9 months, guys. It doesn't even look like there was an ulcer there. And by the way, this is what she looked like when she first came to us. I mean, again, you wanna talk about happy patients. This is what it's all about, right? We don't need billboards, we need happy patients. Our happy patients are our billboards in our community, right? So this was a survey that Varithena did in 2019, and they asked their patients, what do you want? Well, what do we want? Top responses, little downtime, I wanna get back to work, I wanna get back to life, minimal pain, right? Who wants pain? I want it covered by my insurance with little cost to me, I want it to be effective, and I want it to be quick. And again, not gonna read the slides here, but all I'm trying to say is that Varithena is checking all these boxes. Varithena is checking all these boxes. So why I like this, my final thoughts, again, the ease of use, the versatility, the patient satisfaction from less needle sticks. Nobody wants pain. So when you tell somebody I could do something in 2 to 3 needle sticks versus 10 plus, I think you have their attention. Great outcomes, I think we've all shown you that. And I like tortuous anatomy, recurrence of venous insufficiency in our recanalized veins, and C6 disease. So again, this is a very well-tested modality. Over 175,000 patients have been treated, and to this point, no neurological events have been reported to date. Very, very well tested. So make sure when you go back to your practices, if you're not already doing this, please ask yourself, are you making the most of Varithena for your patients? So with that, I'm gonna end the formal talk here and go back to the panel.
Great. So thank you for that. Before you answer this, I have a couple just questions. So we saw in the beginning, a lot of people are not using Varithena, reimbursement, cost, have never had it presented to them in their practice, but people are using physician compounded foam. So with that, what's your response to the physician who says, well, I could get the same results all with physician compounded foam? What would you say to that, Lowell?
Well, I know that's not true with our meta-analysis, that certainly Varithena is superior to the physician compounded foam.
Perfect. And then Vinay, when you have an ulcer patient and there's no, say, reflux that you're figuring out, how often do you look for a venous tributary to get into? And then how often will you just inject the ulcer directly with Varithena?
Yeah,
Can you give me your experience on that?
Yeah, Dr. Sterling. So there'll be situations where you have patients with active C6 disease, and they may just have focal tributaries that are refluxing to the area. And again, I'm not going to stand here and say that every insurance covers that. I know that it doesn't. Obviously, for the insurances that cover it, what I do is I try to get into the most distal tributary that is refluxing, and I try not to pierce through the ulcer, because you can imagine how painful that could be. But every now and then you have an active ulcer, it's so large that you can't get into regular skin. You gotta go through the ulcer, you gotta let the patient know ahead of time. And yes, it obviously is very painful, but many times the patients say, I have enough pain, just help me, just fix this, please. And so sometimes you have to inject into that active ulcer with that needle, with that butterfly needle. But again, try to go as distal as possible. Every now and then you will have perforators around these ulcers, so please be wary of that. Make sure that you're scanning around the ulcers and making sure you can mitigate and decrease the Varithena down those perforators as well as possible. What about
So that's the good question. Now, what do you do with a pathological perforator?
Yeah, no, that's a great question. Every now and then what will happen is, again, these are advanced now, where you have C6 patients and you're looking at around and it's surrounded by perforators, pathological perforators. And you're like, listen, I really wish I could get foam into this. So I'll tell you, honestly, initially I did not, because I shied away from it. But as I thought about it more and more, those are the patients that really are gonna do well. So now what I do is, again, this is not a Boston Scientific back thing. This is just something I do in my practice that I'm sharing with you all, is I will give tumescent, and I will tumesce down the perforators mechanically, and then I will inject the Varithena into the ulcer, because at that point, once you've tumesced down that perforator, you're not really worried about much of that medicine going down. Again, that's just something that I do in my practice. If you'd like to try it, more than welcome to. What are your thoughts, sir?
No disagreement.
Perfect. All right. I don't want to get fired, so I need you to answer this question. Are you getting that? Oh, good. We'll come back for more. So while you're answering this, we want to take your questions, like anything is on the table, okay? So we have mics, any questions, technique, literature, anything.
So one of the things, while we're waiting for a question, I tried to emphasize my stupidity in terms of insurance companies. And it used to be that secondary ablations with Varithena was the only route to go. And I want to make it sure, and that's why I spent a fair amount of time to set Wendy up with the fact that it is a primary indication now.
Come a long ways, yeah.
And
Absolutely.
a lot of insurance companies are informed by third parties that, not just literature that we do, but third parties, ECRI and other ones. And, we are working on behalf of you guys for your patients to help change some of these policies. Now having this living network meta-analysis is really going to help us. And so there's favorable things to come. So, question.
So there were just a couple of comments I had. One of the things that we do in our practice, if you have a pathological perforator and it's below knee disease, we treat the perforator first with our thermal techniques or whatever, laser or any type, and then we would treat the rest of the GSV and the tributaries and the ulcer base, whatever. But one of the things that I've recently started doing is when you get access, especially when you're doing butterfly access, what we're trying to do is put the patient, the wedge underneath. That's when it gets dislocated. The access comes out. So we put the wedge, we take them even more reverse Trendelenburg, and then get access. So then you don't lose the access as often. That's number one. So I think that definitely helps. And the second thing we do is when we have big perforators, which may or may not be refluxing, we try to tumesce those. And there is some people are doing, there's some data people have now. I don't think it's published, but I think people have reported that you can tumesce, you have the tumescent right there, and that helps to kind of compress the perforators. And again, this injecting slow is what's more important than the volume and stuff to prevent DVTs.
I think that's a really important point. With a large GSV, I often use tumescent to shrink that vein as well and to keep it shrunk.
Great.
Good pointers.
I have a question. I mean, whoever can answer it, answer it. Do we know the exact half-life of Varithena? For how long the medicine is actually active? I have heard 15 seconds, 8 seconds, 9 seconds. Do we have any data on that? And can anyone answer this question?
How long is that medicine active for when it's injected? Do we know? Do you have?
It's in the, I would say that not having committed it to memory, but it is in the product brochure, it's actually relatively short.
Yeah, that's the reason that I'm asking is that for how long you're going to compress it, right? Or like if you are injecting and you see something is going after 15 seconds, are you worried for that or not?
Well, here's what I'll tell you. I'll tell you from a clinical standpoint, when you're injecting that medicine, doc, you're going to actually watch it make its way up. Like Dr. Kabnick had a very nice slide. So one of my initial hesitations was, if I start injecting, is this thing gonna fly up and it's gonna be in the deep system somewhere? No, because you're injecting it very controlled. You're watching it go up, watching it snake up the vein with the ultrasound. And to your point, as the medicine's contacting the wall of the vein, it's causing that endothelial denudation. It's not gonna happen instantaneously. In fact, in the trials, they waited up to 30 days to look for vein closure. Right? So this is a process where it irritates the vein, but very nicely, most of the time you can see the vein spasm down. So that tells you have nice wall contact. You want to obviously compress below the junction. But the answer is, obviously it starts on contact. It starts irritating the vein as it's making its way through. And like Dr. Sterling said, it's short-lived. It's not going to sit in your system. It's not an implant per se.
So when it mixes with blood, it deactivates. And I believe that there was an animal study where we cannulated the internal jugular vein, and there was plenty of foam up there, but there was no active.
Right.
But it goes everywhere. But it's the foam and not the active
question.
ingredient.
Hold on. Sure. Go ahead.
Can I? Vinay, have you injected from the knee down to the ankle?
Like a retrograde injection? Honestly, I've heard people do that. Doc, I have not. For me, the only reason I would do it is if the disease is so bad, that the tissue is so destroyed, that it's so hard for me to get access. That would be probably the only way I would do it. But I mean, I'd love to hear the panel speak.
Yeah, so I've done it a few times with leg elevation. It makes sense. Dr. Deek, who published a retrograde, you should read that article with great success.
So it's not like a contraindication per se. But for me, it's just makes sense for me to inject it as distal as possible, so it goes along with the venous return. And if there's some reflux there, that medicine hangs out there a little bit longer.
Well, the other reason just in practice not to do that is depending on the competency of the perforators, you're shooting it potentially directly down into the perforators and into the deep venous system.
Good point.
Potentially.
Anatomically, yeah.
Right.
So in reality, wherever we put it, we're still it's going.
Right.
So even though you want to minimize it, and that's what I think you're saying.
Right. Question right there. Thanks.
One complaint that I hear from insurance companies that people charge 6, 7, 8, 9 sessions of treatment. So I'm wondering, what do you think about it? Is there a limit or not? And do you have to treat always an axial vein to treat a varicose tributaries? Because that was another complaint that, the same axial vein is treated numerous times and they want to charge for it numerous times.
Well, I think that, first of all, that is not a Varithena thing. That is a practice thing. That has nothing to do with Varithena. And yes, as we all know, there are those practices. And people do that. That's a whole separate issue. And I'm happy to let others take that one, but yeah.
Peter, you know there's appropriateness and inappropriateness, and that's totally inappropriate. And it's unfortunate that it occurs throughout the phlebology practices, and we know it, but it's just not in that particular instance. It's indications as well. So we have a lot of work to do in terms of policing.
Yeah.
But is there a limitation, or is there an accepted rule of how many times can you perform sclerotherapy?
Oh, any sclerotherapy? I mean, there's no, unfortunately there isn't. I mean, obviously if you're doing effective therapy, you want to be as much to one and done as possible.
Yeah, no, I think that, Dr. Glutis, great questions. I think that the key thing to your point is making sure that when you're sitting down with the patient and doing the consultation, that you're mapping the vein appropriately, you're talking to them about the treatment. You want to treat that axial vein as best as possible, right? Again, I could share with you, I treat the GSV in one session. I'm not saying that's right or wrong, that's what I do. And then you wait and see the tributaries, do they reflux? Is there any, again, also depends on what the patient's presenting with. What is their SEEP status, right? If they're C6, then I might be a little bit more aggressive in doing more Varithena. But if a patient's coming in with swelling and I can get that axial vein to close, then I agree with you. You don't have to do multiple treatments on that patient. But again, case by case basis, I think.
Everybody's a little bit different. For me, if you're doing a non-thermal procedure, I have difficulty switching to a thermal. And then the question is, are we doing too much if we're treating the truncal veins and the varicosities at the same time? And I would submit that there are studies that probably are in favor of both, probably saying that we're over-treating at first. However, if you look at the quality of life, if you do it one and done, quality of life is better.
Yeah, question over here. Yeah.
I believe Vinay answered that question. When you're treating GSV with foam, you mentioned you do compress the junction, saphenofemoral junction. If you do, for how long? Or depending on the ultrasonic findings?
Yes. So thank you, doctor. So when you're injecting into the thigh component, you want to watch that medicine go up. One of the mistakes I made initially was I would use my ultrasound probe to compress. You want to compress 2 to 5 centimeters below the junction. So we're usually at 3 is our magic number of where to compress. But if you compress too hard, or if you're compressing with the ultrasound probe, then you don't know if any of that vein potentially is getting into a perforator that was missed. So what I would say is use the hand, your hand or your vascular tech's hand to compress. No, not when I say compress, it's not a death grip, right? Because if you compress too hard, then you're resisting the medicine making its way up. So you want to let go, you want to watch that medicine go up. 2 to 5 centimeters below the junction is where you compress. And I, in my practice, compress for at least 3 minutes. That's usually my magic number, at least 3 minutes.
That's perfect. So then you release and you see if it's progressing. If it's progressing, down again.
Yeah, question over here.
What are your nerve-sparing strategies for small saphenous vein ablation?
Small saphenous vein ablations, well, it is not FDA indicated for the small saphenous vein at this point. I think that's all we can mention at this point. But offline, I'd be happy to chat with you about what I do in my practice. Anyway.
Well said.
Very well said for a sponsored symposium, but yeah. Other questions? All right, I have a question for the panel. Some of the logistics about Varithena is you're trying to maximize your canister over a certain period of time. And so for certain practices that aren't doing, like 9 treatments on every patient, how do you do that in terms of getting your patients scheduled? Does your office do that? Do you try and stack them? Yeah. Tell me about how you manage that.
So I call that canister economics, right? My thing is very simple. And again, I'm not sitting on a soapbox in any way. For my thing is that you treat the patients for the disease process. I'm not worried about how many cc's I used and how many cc's are left. Some people do, and that's their business. But in my practice, whatever is necessary, we do. If we need to give 8 to 12 cc's of Varithena in a GSV, and I know that I'm going to be able to bill for 1 GSV, that's what we're going to do. But there will be sessions where we have patients that come in that have tributaries that are refluxing at an ulcer, and I'm using 3 to 4 cc's. And so yeah, I'm gonna get more usage out of the canister, but I would not chase the economics of a canister. If you're starting out, obviously common sense being common, you don't wanna have one Varithena case every other month because then the canister is gonna expire. You don't want that. You wanna be obviously smart, diligent. So yes, in the beginning, you probably wanna line up cases so you have enough for a canister to be utilized. But as you become well-versed and your practice grows with the Varithena, don't chase the cost of the canister. Just make sure that you're continuing to practice good medicine. That's the best way I would answer it in my practice. What about you, Dr. Scott?
So when we first started, we had far and few between.
Yeah.
And we had to be careful. And so there are all sorts of ways to game the situation. And some of my colleagues would share canisters off the record, would share canisters between practices. Now that we're pretty much game, there's no issues.
Right, and I could say that from my personal experience that, you know, when you start out, it's like anything else, you want to be judicious.
Exactly.
But I think it's like a lot of things. When you start doing it and you get comfortable, now you're going to find more patients that you're going to want to do. And I think in the early years, even before Boston Scientific had Varithena, you know, insurance were challenges, living in your secondary only. But now, as there's 90% plus primary coverage, you can do it, and so you'll find that the patients can have this or thermal, and since you're going to present all the data tomorrow.
So remember about transfer packs and how much you're supposed to withdraw and insert, because people are also gaming that as well, and it's wrong because you want consistent microfoam. That's why Varithena is the go-to as opposed to physician compounded.
Right, exactly. Yes, we want you to use it in a responsible way. Yes. Any other questions?
Do I combine in the same procedure? Okay, so there are situations, obviously I'm looking at the patient ahead of time, I'm looking at their insurance, I'm seeing, you know, what they allow and don't allow. And in a situation where I find that the patient has a GSV that needs reflux, that needs to be treated, I treat them with Varithena, so I'm not worried about doing a combo. But every now and then you have a patient that does not have an insurance that recognizes Varithena. And so for those cases, if they're above C4 and above, I will go ahead and do a combo in the same setting. I will not bring them back. But again, that's just me in my practice. I'm not saying that that's right or wrong.
I would like to comment on some of our practices and looking at one and done type of practices and treating to the lowest point of reflux. I think we don't know enough about the pathophysiology of venous disease.
Yeah.
And perhaps, and just a consideration, is that we're treating too much. And I think it really depends on the disease process. And I will treat more if there's advanced venous disease than I would for a C2 patient. Because I think as long as you decrease the venous hypertension, you're going to ameliorate the symptoms. You may have more recurrence, and then we're talking about so-called aesthetics. So I think we need to be careful, and I suspect the analogy that I'm talking about is breast cancer, when we used to do radical mastectomies, and that shifted to modified radicals, down to mastectomies, down to lumpectomies. And so the more we know, probably we'll be doing less, and Varithena is going to be perfect for that.
Yeah, and I like the way you showed the double catheter technique and realized that you can use that double catheter technique above the knee as well. So if you access below and then you hit a stopping point or a real tortuous point, you just access right above that to get the more central aspect. All right. Oh, another question.
Is your treatment algorithm different for the patient, symptomatic patient with isolated calf segment reflux with the GSV?
I think it would depend on where they are on the spectrum of venous insufficiency. If they're a C4 and above, then yeah, my tendency to treat that isolated reflux is going to be a little bit higher. But if I'm going to look for other causes at that point. If it's very, very focal, I'm not going to chase isolated reflux in my practice.
Yeah, great.
Totally agree.